All right, here we go. It's endocrinology. We are on week 4. It's Monday. Diabetes insipidus and SIADH, syndrome of inappropriate ADH secretion. So let's talk about diabetes insipidus. It occurs when the kidney fails to correct hypernatremia or hypervolemia via ADH, right? Because normally if you become hypernatremic, you need to bring more water into the blood, and that's done by the release of antidiuretic hormone. From where? Magnocellular neurons, from the supraoptic nuclei mainly. And yep, same with hypovolemia. How does that mechanism work? What does that stimulate the release of ADH? Through angiotensin II, R2A system. Angiotensin II can bind to magnocellular neurons and cause its release. All right. What are the symptoms? Well, if you can't suck free water out of the kidney, out of the filtrate, out of the urine, then it's going to go into the urine, so you're going to be urinating all the time. And that's called polyuria, or diuresis is another way. Now you should know both of those terms. You could also say that the urine is hypotonic. Hypotonic. It's kind of like hyponatremic, where it's water rich and sodium poor. So that's another word you should know, is hypotonic. So too much water. Urine has too much water in it. Or you could say the urine fails to concentrate. The more it concentrates, the more sodium and other ions are in it. How much do they urinate, someone with diabetes insipidus? At least 3 liters per day. And typically 15, 17, 18 liters per day, up to 20 liters per day. And that is, you're going to the bathroom probably every hour or so. So also, if you're losing so much water in the urine, what's that going to do to your thirst? It's going to make you thirsty. So you're also going to have polydipsia. Polydipsia is, poly means lots of, like polydactylia. So polydipsia means you're thirsty. You're drinking water, or you're craving water all the time. What about diabetes insipidus versus diabetes mellitus? Insipidus means tastelessness. And so, heaven forbid, if you had to taste the urine, which they had to do back in the day, or smell it at least, it would taste waterless. That means insipidus. And why is it waterless? Because you're not absorbing any free water. So you have too much water in your urine. Unlike diabetes mellitus, where you've studied that, I'm sure already, where too much glucose is in the blood and it gets into the filtrate, and all of it can't be reabsorbed, and so you get glucose in your urine, and if you were to drink it or smell it, it would smell sweet. That's the difference between the two. In reality, though, you're normonatremic. So because the polydipsia, as long as your thirst centers are working okay in your hypothalamus, you are going to drink too much water, and that'll compensate for the hypernatremia. Right? So again, you can't, in this condition, without ADH, you can't suck free water out of the filtrate, so it's going to go. And what's that going to do to the blood? It's going to make the blood water poor, or you could say sodium rich or salty, and that's going to make you thirsty. So normally, if you're thirsty and drink tons of water, you're going to compensate for that hypernatremia. And so most people with diabetes insipidus, especially early on, are normonatremic. That means normal sodium emia in the blood. So they're not hypernatremic at first. Now, if you have a mutation or something in the the hypothalamus and the thirst centers, and you don't get thirsty, now you're in really big trouble, as we'll see here in a second. And that second is here. So if you can't drink lots of water to compensate, let's say you're in a desert island or something like that and there's no water around, or the thirst centers are messed up. If you can't drink water, you're in big trouble. You're going to become hypernatremic, and the body doesn't tolerate hypernatremia. It doesn't like salty blood. You could also say you're hyperosmolaric, or hyperosmolalic is another one. Yeah, so what's your body going to do? You can't have salty blood, it'll kill you. So it's going to suck water out of all the cells in your body, including the brain cells. So that is not a good thing. Did I not say that? So neurological sequelae, did I miss a slide here? Yeah, these slides are out of order, so we should go to here. So you're going to suck water out of the blood and out of the brain cells, so you're going to develop what's called hypertonic encephalopathy. Hypertonic encephalopathy. Hypertonic is short for hypertonic sodium gain. So if you suck water out of a brain cell, here's a brain cell, and here is, let's say, never done this before, so bear with me. Let's say that that doesn't show up very good. Let's make them red. Here's sodium out here. Way too much sodium. We'll just make 4 of them. So way too much sodium in the blood and in the interstitial fluid. So the cell, let's make water green. The cell has these water molecules in it to make it happy, but because the blood in the extracellular fluid is so salty, you need to fix that. So you'll suck the water molecules out of the cell, and the cell will shrink, for one thing. And then the cell has sodium in it as well. The sodium are going to build up inside the cell. Right? The sodium are going to lose the water. So your cell is going to become hypertonic. Right? That's where hypertonic sodium gain comes from. And it's very dangerous. I mean, it wrecks your brain cells. So that's not a good thing. So, yeah. And normally, ADH wouldn't let this happen because that saltiness would be diluted with water being reabsorbed from the kidney. But for whatever reason, the ADH isn't working. Right? So that's what I said. The only place to get free water is from the intracellular and extracellular fluid. And it literally sucks the water out of your cells, and your cells physically shrink, and it kills your brain cells, and that's a really bad sign. And the signs of that, of hypertonic encephalopathy, clinical signs, are seizure, coma, death, hyperreflexia, signs of an upper motor neuron lesion. You can get a bleed in the brain because of this. It sucks the water right out of the endothelial cells of the arteries as well, of the cerebral arteries, and they can start bleeding. You get altered sensory function and lethargy. So classic signs of hypertonic encephalopathy. Now let's go back and do that other slide. Where was that thing? So this, I got to figure out where to put the slide. So what are some other findings of hypernatremia that could indicate that you are hypernatremic besides all those? I mean, these are the end. Maybe that's why I put that here, because these are extreme signs. These are the end signs of hypernatremia. When it starts sucking water out of your cells. The first signs that show up, I should have said first signs of hypernatremia. Or I could have said the first signs of diabetes insipidus would have been better. Maybe I'll change that if I can remember. Let's slide number 9. So orthostatic hypotension can start. If you can't return water into the blood, you're not going to have as much blood water around. And so not only are you going to be hypernatremic, but your blood pressure is going to start to drop. And therefore, orthostatic hypotension means that when you get up from a supine position or prone position, You stand up, you get really, really dizzy. You could even pass out. Your blood pressure drops, and that's because of hypotension. And I was going to tell you that story about POTS. I had my first case of POTS disease, which is worse than orthostatic hypotension. When she gets out of the bed, if she's not very careful in the morning, she can get so dizzy that the whole day is ruined for her. And that's a weird syndrome with vomiting and all kinds of crazy stuff. But I'll try not to digress. I'll stay on point. Abnormal skin turgor. That's if you pinch the skin on the back of your forearm or right under the collar. Everybody take your skin under your collar right now, under your clavicle, inferior to that, and just pinch it. I'll even do it. Pinch your skin, give yourself a pinch, and see the skin snaps right back. People who have low blood pressure and are hypernatremic, that skin will stay bunched up. That's another way they check for dehydration, right? So skin turgor is messed up. Tachycardia, if they have hypotension, the heart will try to make up for that by pumping harder, and that's hypotension. So that causes tachycardia. Probably tachypnea as well. That always gets left off, but if your heart's going faster, your respiration rate's going to be increased. And then if severe, that's when the hypertonic encephalopathy occurs, and that's the nice lead into that. And as we said, it literally sucks water out of your brain cells and kills them, and gives you really stroke-like symptoms. That's kind of one word to summarize all that up. What else can hypernatremia do? Well, let's see, loss of body water, or what else can cause hypernatremia besides this diabetes insipidus? Diarrhea. Anything that causes hypovolemia, that causes more body water loss than salt loss, will do it. So diarrhea and vomiting, hyperhidrosis, burns. Diabetes mellitus is interesting. That can cause hypernatremia, but by a weird mechanism. So the nephron can't return all the glucose to the blood. So if you get glucose molecules going through the filtrate, glucose is very magnetizing. It's polar, and it can grab and hang on to water, and therefore not let the water return like it's supposed to. When ADH has an effect, water's supposed to flow out of the collecting ducts, and it can't if glucose is bound to it. So you can start to have hypotension, hypovolemia, and hypernatremia from diabetes as well. That's important. I always ask that question. Chronic kidney disease, where you can't return sodium into the blood or glucose into the blood, that would do the trick as well. Or no, I shouldn't say, that's not right. You can't return sodium, where you can't return glucose to the blood. Because if you can't return sodium to the blood, then you're going to become hyponatremic. We're talking about hypernatremic. It's another one I got to fix. 9 and 13. All right, so what's the cause of this diabetes? How come the ADH isn't doing its job? There's 3 types of diabetes insipidus. There's central diabetes insipidus, nephrogenic diabetes insipidus, and a rare one, some authors don't even include it, but dipsogenic diabetes insipidus. So let's talk about them. Central diabetes insipidus has some AKAs that give it away. Hypothalamic diabetes insipidus, neurogenic diabetes insipidus, cranial diabetes insipidus. So this is going to involve the hypothalamus, so we already can figure what's going on here. So the problem here is that ADH is not being made by magnocellular neurons, or something's wrong with the neurons. It's not transferring down to the posterior pituitary, or maybe the neurons are being pinched by a pituitary tumor. So for whatever reason, ADH is not getting out of the posterior pituitary. That is central diabetes insipidus, and this is by far the most common cause of diabetes insipidus. And the next question is, well, what can cause this central diabetes insipidus? How come ADH isn't getting into the bloodstream? The most common cause is pituitary gland surgery. So that's said to be iatrogenic, meaning man-made problem. All right, so during the pituitary surgery, maybe it's one of the most common tumors in the pituitary is a prolactinoma, a tumor in the anterior pituitary that's made up of the cells that secrete prolactin. And when they go in to remove that tumor, they might crush the posterior pituitary, or maybe the pituitary gland itself has crushed the axons of magnocellular neurons. But we're on iatrogenic, so they go and do pituitary gland surgery, and the blood and swelling maybe after the surgery crushes the magnocellular neuron axons, and you don't get any ADH coming out. You can have autoimmune disease, which attacks the pituitary gland or magnocellular neurons. Maybe it attacks the hypothalamus, the supraoptic nuclei. So autoimmune inflammation can do it. A compressive tumor of the pituitary gland, like I said, prolactinoma is the most common. Congenital gene mutations, maybe you just can't make ADH. So you can have, you're born with gene mutations. One factor is called familial hypothalamic diabetes insipidus, where there's a mutation in the arginine vasopressin gene that makes ADH in the magnocellular neurons. Right, and then sometimes it happens and we don't know why. It's probably a virus or some infection. How do these people present? Well, they present with diabetes insipidus. So they have polyuria. We can add, if you're peeing all the time, you're going to be getting up at night to pee all the time. So that's nocturia. You're peeing at night 4 or 5 times. And then you're always thirsty. So there's 3, polyuria, nocturia, polydipsia. That can go with all of these conditions. When you do a urinalysis, which you can do in your office, the urine is hypotonic, meaning there's way too much water in it. It's too water heavy. You'll learn about specific gravity when you get to Dr. Dumani, I think, teaches that. Has to be at least 3 liters of water, urine coming out per day. Usually it's more like 10 to 15 to even more. You can do some blood work, and you'll find that there are no ADH levels. No ADH levels, and you're hypernatremic on top of that. So too much sodium, not enough water. But remember, we said typically these patients are normal natremic because they compensate by polydipsia. They're thirsty, so they compensate by drinking tons of water. So not only will they be peeing all the time and at night and thirsty all the time, they're drinking tons of water. They're drinking 4 or 5 liters of water per day, or even more. So those are a sign of something's messed up. All right, now we have nephrogenic diabetes insipidus. This is a different story. Nephro, that's for kidney. So this is something's wrong with the kidney. And the kidney is said to be resistant or insensitive or non-responsive to antidiuretic hormone. There's nothing wrong with the thalamus or pituitary. Its ADH is being released just fine. But the kidney is not receptive to it, is the problem. Typical presentation is the same: polyuria, nocturia, polydipsia. And as long as the thirst centers are working, they're not going to show up with a hypernatremia. They'll have a normal natremia, but they'll be drinking tons of water. And they'll be urinating. They'll be getting up 5 times at night. So that's the way you tell this condition. What causes this one? Interestingly, again, it's iatrogenic, meaning it's a man-made problem. And its number 1 cause is from lithium, which is a drug used for bipolar and manic depression, some more serious psychological disorders, which works pretty good. But it has some pretty bad side effects, and this is one of them. And what does the lithium do? It soaks into the principal cells, and it interferes with aquaporins 2. Remember, aquaporins 2 has to be made. It's not in the, like aquaporins 3 and 4 is always in the principal cell basolateral surface. Aquaporins 2 has to be made when ADH binds to the principal cell. So yeah, so it messes that up, and if you can't make aquaporins 2 channels, you can't get the water out of the urine. You can't get the water out of the filtrate. And yeah, almost a third of patients who are on long-term lithium therapy end up with at least some degree of diabetes insipidus. What's another cause? Another common cause is diabetes mellitus that isn't controlled very well, and we just talked about that mechanism. Let's see. Chronic hyperglycemia makes the kidney. So we talked about how the sugar in the urine can bind water too, right? And it can take water right past the principal cells in the collecting ducts. But excess sugar also blocks the implantation of aquaporins to transporters. So that's yet another mechanism that diabetes mellitus can cause a diabetes insipidus type syndrome. Right. Gene mutations again, so congenital condition, you're born with gene mutations. And yep, so they've been found in the genes that create V2 receptors. So some people don't have V2 receptors, so they can't bind ADH to the principal cells very well. So there's gene mutations that make aquaporins 2 channels. And there's some regular proteins that's too complicated, but there's other gene mutations that have been found. So those are all ways that you can get nephrogenic diabetes insipidus. Now, dipsogenic diabetes insipidus, Goodman doesn't even talk about it. It's also called primary polydipsia. It's really rare, but let's talk just a tiny bit about it. Now, this occurs when the patient just drinks too much water. They're just always thirsty, and they have hyperdipsia, and they're always drinking water. And therefore, if you drink way too much water, where's that water going to go? You're going to end up urinating it out. So they're going to have polyuria and nocturia, which will be tasteless, and you'll have a hypotonic urine as well. What's the cause of this? Let me look at one thing here. Yeah, I got that one. What's the cause of dipsogenic? We don't know what it is. There's some new research that shows that the thirst centers in the hypothalamus of gene mutations are messed up, where they just always are on and make you thirsty. Interesting, schizophrenic patients, about 20, and this is not related to any medication either. This is not lithium based. They can go on other medications. 20% of schizophrenic patients just drink too much water out of habit. They like to lick their lips as well. Talk about that in dermatology. All right, so what's the treatment? So you got diabetes insipidus. What is the treatment for this? There is something called desmopressin. Anytime you see desmopressin, a pressor agent, think of vasopressin. It's going to cause water to come into the blood. So this is a very important antidiuretic. So diuresis means losing water in the urine. So anti means stopping the loss of urine stopping the loss of water into the urine. It's also considered an ADH agonist. I guarantee you I'm going to say ADH antagonist. Got to know the difference. I'm teaching first quarter right now, the difference between agonist and antagonist. An agonist is going to put the cell in agony when it binds and makes the cell work. An antagonist is a blocker, so the cell won't be in agony, it just gets blocked. So it's considered an ADH agonist, or it's considered a pressor agent, like vasopressin again. So these all do the same thing. They cause the reabsorption of free water. So how does it work? How does desmopressin work? It binds to ADH V2 receptors on the principal cell basolateral surface, and it acts just like ADH does. It stimulates them to, through the central dogma, create aquaporins 2 channels. and we know how that works. They're put in the luminal surface and water comes flying out of the filtrate. This desmopressin is twice as potent as natural ADH is. This obviously would work best for nephrogenic diabetes insipidus. Number one complication is it works too well, and so you get a hyponatremia. Yep, too much water is reabsorbed, and you get too much water. You get a watery blood instead of a salty blood. What does hyponatremia do? Headaches, bloating, hypertension, occasional seizure if it's bad enough. All right, so that's enough about diabetes insipidus. Let's talk about SIADH, syndrome of inappropriate secretion of antidiuretic hormone. So what is this all about? Well, too much ADH is around in the serum for whatever reason. If you have too much ADH around, it's going to overstimulate the principal cells. You're going to suck too much water out of the filtrate, and that's going to go into the blood and cause hyponatremia. You're going to have watery blood. Right? What's it going to do to the urine? If you suck too much water out of the filtrate or the urine, you're going to have a very salty type of urine. So, yeah, that's the story there. Hypertonic urine you'll have. Yep, the cause, what's the cause of SIADH? Well, ADH is supposed to be turned off. There's a bunch of causes we'll look at. But normally ADH is turned off by hyponatremia, right? By watery blood. If your blood's getting too watery, you don't want to release ADH to make it more watery, so you turn it off. So for whatever reason, the potassium content or the sodium content of the blood is not working, and ADH is being secreted all the time. There's 4 different types. We're not going to get crazy into the weeds on this one because it's pretty rare. The most common cause, though, is some fun facts about it. It is the most common cause of hyponatremia in clinical practice. So it is around about 30% of those who come in with hyponatremia have SIADH. And that's the hallmark, hyponatremia, or hypoosmolarity. It's the hallmark of this condition, and it can become fatal. So now what are the causes? So we have acquired causes, some other disease process in the body, which we'll look at in a minute. It could be congenital as well, meaning you're born with it. That's called hereditary SIADH. So there are mutations in the aquaporins 2 channels again. But these are interesting mutations. They're not broken. They're called function of gain mutations, mean that they're the opposite of broken. They work too well and can't be turned off. So these mutated aquaporins 2 channels, once you stimulate them with ADH, they don't shut off like they're supposed to. And way too much water comes in. And yeah, you get a hyponatremia because of that. What are some causes? So central nervous system diseases, stroke, bleed into the brain can cause this. And all of these central nervous system diseases, they stimulate the magnocellular neurons to release ADH when they're not supposed to. So bleed, a stroke, an infection, meningitis can cause that. You could have a cancer, small cell carcinoma, small cell lung cancer, or small cell, all these aka small cell bronchiogenic carcinoma. That's notorious for the tumors of that lung, or the cells of that lung tumor are notorious for releasing ADH. In fact, it's the most common form of ectopic ADH overproduction is small cell carcinoma of the lung. Let's look at a 41-year-old man who comes in with headaches, neck pain, back pain, chronic cough for the last 8 months. He's got a history of 20-pack per year smoker, heavy smoker. Blood pressure is 160 over 107. So you take a chest film of him. I don't know have you had soft tissue pathology? I'm not sure if you've had that yet. But what's a possible endocrinological diagnosis based on this chest film? And I don't teach in gross anatomy anymore, the lab, but I used to test you on this picture. Hopefully they're still testing you on this stuff in gross 2. But you're going to be fooled, because some of you are going to think this is the aortic knob. What's the aortic knob anyway? That's where the aortic arch turns downward, kind of rounding the corner and turns into the descending aorta. That's not the aortic knob. The aortic knob is up here, more by the manubrium, by the sternal angle of Louis. That's not good. That's a big mass in the lung, and it turned out to be a tumor, bronchiogenic tumor. And it turned out to be a secretor. And what did it secrete? ADH, and that caused hypertension in this patient, and polyuria. Didn't I put polyuria? I should add that in there as well to the story. That might have helped with the diagnosis. Yeah, or no, they wouldn't have. That's why I didn't add it. You won't have polyuria, right? If that's secreting ADH, it's going to be sucking all. It's going to be sucking all the water out of the filtrate, so you won't be urinating very much. You'll just have really watery blood and hypertension because you have hypervolemia. That's where the headaches came from, right? Headaches came from the hypertension. All right, some more causes of SIADH. So there's common drugs, really common drugs, right? SSRIs, Zoloft, Paxil, Prozac. I mean, those are big names. We've heard those names. Doesn't happen to everybody, but some people it can stimulate the magnocellular neurons to overproduce ADH. And there you go. Then you're diagnosed with SIADH. Anti-seizure medications will be used to treat chronic sciatica in some patients. Antipsychotic medications, ecstasy, desmopressin, which is used to treat von Willebrand disease and some of the hemophiliacs. So these are fairly common drugs. Doesn't happen all the time, but it can. It is one of the complications. Status post-surgery, the trauma from that can sometimes stimulate the overproduction of ADH, pneumonia, hyperthyroidism, HIV infection. So how does someone present with, we kind of talked about this already, clinical presentation? They're going to have hyperosmolallic urine or hypertonic urine. In other words, urine. I was thinking blood. How can it be hypertonic? No, the urine. All the water's been sucked out, leaving the salt. So you have salty urine. So you'll have hypertonic urine or hyperosmolallic or hyperosmol, all AKAs, urine. Too much free water's been sucked out of the filtrate. We said that already. Yeah, and that's one of the big requirements for the diagnosis is the urinalysis. What will the blood look like? The blood's going to have too much water in it, not enough salt, so you have hyponatremia. And you never, I'm not going to, maybe Dr. Dumani will ask you these numbers, but I'm not going to ask you numbers. What are some differential diagnoses? A big one is Addison's disease. Well, how in the world could Addison's disease be a differential diagnosis? Well, what does Addison's disease do? It wipes out the adrenal cortex, so you can't secrete aldosterone. If you don't secrete aldosterone, you can't reabsorb sodium, so you're going to be hyponatremic because of that. Also, you're not going to secrete cortisol. Remember, cortisol is important to turn off magnocellular neurons. It has receptors for cortisol and turns it off. So if you have no cortisol around, there's no reason for magnocellular neurons not to secrete ADH. Strong differential diagnosis. So what are the symptoms of hyponatremia? Well, there are neurological symptoms of hyponatremia as well, where you basically, instead of sucking water out of the cells, it sucks salt out of your cells. And yeah, you can get headache, weakness, lethargy, nausea, vomiting, all those kind of stroke-like symptoms, seizure, coma, neurological deficits. And yeah, in reality, that typically the water uptake is not bad enough to cause hypertension, so it has to be pretty bad. Just kind of a side note there. It doesn't always show up like that. How do you treat this? Well, if you have too much water in your blood, there's no reason for you to drink water, so you get put on a water restriction where you drink maybe a liter of water a day and that's it. And then if the blood is too much salty or too much water in it, well, add some salt to it to balance things out. So you have to take salt tablets or get a salt IV, saline IV to kind of normalize your blood. You can also try glucocorticoid replacements because maybe you do have Cushing's syndrome. If you take glucocorticoids, it will bind or will try to bind to the magnocellular neurons and shut off that ADH production. Of course, the problem with that is maybe that's not the problem. If ADH is being released from a tumor or something, that's not going to work, is it? So you can also block the V2 receptors, which is what ADH binds to. So they're called V2 receptor blockers, antagonists, not agonists. Agonists cause agony of the cell. This blocks the cell. And yeah, we can do that. Okay, that's it. See y'all later. Hi guys, Dr. Gillard here. I'm putting both this one and yesterday's lecture on YouTube. Damn virtual classroom dropped the audio. So forget it. This one's going up there too. I'm getting fed up with that platform. Anyway, it is endocrinology. It's the spring of 2021. It is week 4. Get my laser pointer here. And the star of the show today is ACTH, or adrenocorticotropic hormone. We'll talk about CRH and a little bit about how stress can drive this system. Not a lot of disease today. So ACTH, it's also known as corticotropin, adrenocorticotropin. It is a member of the corticotrope family. Some authors say corticotrope. Some authors say corticotroph. And guess what cells it's secreted from? Corticotroph cells, or sometimes they say corticotrope cells, which live in the anterior pituitary, one of 5 cell types of the anterior pituitary. It is a member of the HPA axis, the hypothalamic pituitary adrenal axis. It's a member of that. It's also a member of the HP axis, the hypothalamic axis. It is the only corticotroph that we know for sure what it does. The other ones are a little mysterious. We'll look at the other ones in a second. One of them, alpha MSH, we know a little bit about that one, but there's some hormones that come out of the adrenal gland. We just don't know what they do for sure. Anyway, ACTH, what does it do? Should be review. It stimulates the zona fasciculata and it stimulates the zona reticularis. We could say it stimulates the adrenal gland. The question could say it stimulates the adrenal cortex, or it could go deeper. What layers of the adrenal cortex does it stimulate? Mainly the zona fasciculata and the zona reticularis. Remember, it stimulates the zona glomerulosa a tiny bit. It causes the release of a little bit of aldosterone, not a whole lot, not really clinically significant. So if it stimulates those zones, what comes out of those zones? So out of the zona fasciculata, we have cortisol via fasciculata cells. Out of the zona reticularis, via reticular cells, we have DHEA. Some authors don't. I've noticed I've been doing more reading on this. Some authors also just call it androstenedione, or androstenedione, however you like to say it. So you may see that, or you may see DHEA. What else here? That's about it for that one. And here's just a recap. I know I've shown you this before, but just to kind of warm up your brains, there's the cartoon of adrenal gland sitting on top of the kidney. Remember, the adrenal gland has a capsule which does nothing. Then it has the cortex in kind of orange here. And then it has the medulla inside. And the cortex is made up of those three zones, right? Zonula, zona glomerulosa, zona fasciculata, zona reticularis. And each one of those zones have cells that are named after the zone: glomerulosa cells, fasciculata cells, reticular cells. And they secrete, or they're stimulated by angiotensin 2, zona glomerulosa, potassium ion, increased potassium ion. They release, what do they release? Aldosterone. Right? Zona fasciculata releases cortisol, stimulated by ACTH only, normally. And zona reticularis releases DHEA, or you could say androstenedione or androstenedione, whichever way you'd like to say it. The medulla is stimulated by angiotensin 2 and sympathetic inflow to release the catecholamines, epinephrine, norepinephrine, a little bit of dopamine. All right, there's your review there. Other corticotroph cells, so there are some other corticotropes besides ACTH. There's one called melanocyte-stimulating hormone, MSH, and there's actually three flavors. There's even more of them, but there's three kind of mainstream flavors. There's the alpha, beta, and gamma MSHs. The only thing we think that we really know what does something is this alpha MSH, and we'll look at that. I won't spoil the surprise, but they're not super well understood. How do we make ACTH? Well, we said it's made by corticotroph cells, live normally only in the anterior pituitary. So the first thing that has to happen, it needs to be stimulated by something, and the main stimulator of the making of ACTH is corticotropin releasing hormone, or CRH. A little bit more specifically, the CRH, as well as antidiuretic hormone, as we'll see here in a second. I call it antidiuretic P, meaning it comes from parvocellular neurons, not the one that comes from the magnocellular neurons. But yeah, both of these travel through the hypophyseal portal system, and they bind to the receptors on corticotroph cells. CRH binds to CRHR1 receptors. What happens if you have a mutation in these receptors? Well, you're in trouble, right? You can't make cortisol, and you probably won't live very long. And DHEA. But yeah, so those are corticotropin releasing hormone receptor 1. That stands for, you should know what that is for one of those really hard board type questions. And yeah, and we won't get into worry about the ADH-p receptors. Those are not the same receptors, they're different receptors. But the binding stimulates the release of, now technically, if you really want to know how this works, ACTH is not directly released from corticotroph cells. A hormone called pro-opiomelanocortin, or POMC, is a prohormone. It's a precursor form of ACTH, and that's released. It's immediately acted on by an enzyme called prohormone convertase 1, PC1, which immediately chops off its tail, and that gives us our adrenocorticotropic hormone, or our ACTH. So depending, I'm sure the board question would probably would forget the POMC, but maybe a hard board question may not. So I've got to teach you both of those the correct way. So, and warn you that the board question could say either of those. There is a prohormone convertase 2, or a PC2, which lives in the skin. There's a question right there. PC2 does not live in the adrenal gland, the anterior pituitary, doesn't live in the adrenal gland, it doesn't live in the pituitary gland, it lives in the skin. PC1 is the one that lives near the corticotroph cells in the anterior pituitary gland. Now, how does this work, PC2 work? So if you have really high levels of ACTH, so let's say you have Addison's disease, which we've talked about, so your adrenal gland isn't secreting cortisol, and probably not secreting anything, ADH, or it's not secreting aldosterone, and it's not even secreting androstenedione. So none of the adrenal hormones are coming out. You're going to have really high levels of ACTH, right? Because there's nothing to shut off the AHP axis. So remember, cortisol, double negative feedback system, it shuts off the production of ACTH. There's nothing to do that if there's no cortisol around. So you have super high levels of ACTH, high enough that they start soaking into the skin, and that's where PC2 lives. And its affinity to ACTH isn't super high, so you do need high levels of ACTH to make this work. But if there are high levels of ACTH, PC2 will bind to ACTH and chop off its tail and make a new molecule called alpha MSH, melanocyte-stimulating hormone. And alpha MSH is going to do its thing. As it says, it stimulates melanocytes in the stratum basale to overdo their thing. And what do melanocytes do? They overinject melanin into the keratinocytes. Remember their job from histology? So there's a melanocyte with alpha MSH around. It makes these crazy, and they overinject cells in a certain region. So what happens is you get a blotchy type skin, like this person has who has Addison's disease. Okay, so they get a blotchy skin. Some differential diagnosis we'll learn in dermatology. Vitiligo, melasma can look a little bit like this, so there are some differential diagnoses. But she's got a little moon face starting here, and she's going to have some of the other symptoms. We'll get to Cushing's syndrome. CRH, so let's talk about that. We said its main job is to stimulate corticotroph cells to release POMC/ACTH. CRH is released by neurons that live in the paraventricular nuclei of the hypothalamus. I think we've said that before. And these neurons are called parvocellular neurons. So the PPs, parvocellular neurons, live in the paraventricular nuclei. Now they're not like magnocellular neurons. Where do magnocellular neurons live? In the sun, SON, superoptic nuclei. They release ADH. They have very long axons that go all the way down to the posterior pituitary. Not the story with parvocellular neurons. They have short, stubby axons that don't go that far. In fact, they end at the bottom of the hypothalamus as a region called the median eminence. And that's where the hypophyseal portal system starts. So they dump their CRH right into this little capillary system called the hypophyseal portal system, and they're taken immediately down to the anterior pituitary, where they're released into the interstitium, and they swim a short distance and bind to their corticotroph cells and do their thing, which is to make POMC, which is converted into ACTH. Remember that? I think we showed you this before, but here's parvocellular neurons here in the paraventricular nuclei, and they have short, stubby axons. They dump their CRH into this hypophyseal portal system, and the blood flow is this way through this little arterial system here, and blood is taken down by this part of the hypophyseal portal system, and it's dumped into everywhere here. And corticotroph cells are in pink. They grab the CRH, and it stimulates the release of POMC/ACTH. Okay. Notice the superoptic nuclei over here, the magnocellular neurons, are really long, and they're able to take their product, which is ADH, all the way down here. And remember, let's not forget the parvocellular neurons also release ADH-p, we'll call it. And that's short too. It takes the same route. And so there's little ADH going down these long axons. So technically speaking, ADH is released into the posterior pituitary as well as the anterior pituitary. It's just different. They just have different functions. Right? All right, and ADH-p. So again, parvocellular neurons also secrete a little bit of antidiuretic hormone. and we'll call it ADH-p just to let you know that it's coming from parvocellular neurons. So again, it's released into the hypophyseal portal system. It binds to corticotroph cells. It has its own receptors, though. It doesn't use the same ones that CRH does. And normally it stimulates a little bit of POMC. It kind of enhances the effect of CRH normally. The key is with stress. We'll see with stress, this hormone becomes much more important and really drives the overproduction of ACTH. Parvocellular neurons, what else do they do? They also secrete thyrotropin releasing hormone, and we'll get to that if we have time later on. All right, here's just kind of the big picture of where we've been. So we have parvocellular neurons releasing mainly CRH, a little bit of ADH-p. They both stimulate corticotroph cells in the anterior pituitary to release pro-opiomelanocortin, which is immediately converted by PC1, which we're still in the interstitium of the anterior pituitary. PC1 converts POMC into pro-ACTH into beta-lipoprotein hormone, which we don't need to worry about this pathway. See, it's more complicated. And then, if you really want to get technical, POMC is double spliced. You have a pro-ACTH that's converted in the first splicing, and the second chopping of the tail of POMC gives us our ACTH, as well as some other hormones as well, which we don't really know a whole heck of a lot about. This one we definitely do. ACTH, of course, hits the adrenal cortex and causes cortisol release and DHEA release. But it also, if you get increased amounts of it, it can also get into the skin, where this little circle means this is happening in the skin, where PC2 converts it into alpha MSH. Alpha MSH stimulates the melanocytes to over-pigment their region of keratinocytes, and you get that blotchy suntan-like thing. Fun facts about CRH. There are other CRH containing and releasing neurons in the CNS. So in the brain, there's more of these things, and we don't understand what they're doing there. So CRH is a lot more important than just, that's super important too. It's important. You got to have it for life, right? You have to have cortisol. But there's other things we're still discovering about it. It's also produced during pregnancy in the placenta, which we're not going to get into, and that's kind of not a mainstream concept there. How is CRH regulated? Well, that's easy. We just said that already. It's that cortisol double negative feedback system that we've talked a couple times about. So the increased cortisol will directly bind to parvocellular neurons and shut them off, so they don't make CRH or ADH-p. And without that, you can't make ACTH. Just in case what if there's a gene mutation on the parvocellular neurons, and cortisol won't bind to them and shut them off? That's okay, because cortisol also binds to corticotroph cells, and it can shut them down as well. So it's double negative feedback system. Didn't I have a picture of that? Where it is? There it is. So there's cortisol. What we have, let me see if my little drawing tool working. Oh yeah, it's working. So let's say we get too much cortisol in the blood, over elevation of cortisol. Cortisol will flat out bind to parvocellular neurons and knock these two guys out of action. With those two guys out of action, you can't drive corticotroph cells to make POMC ACTH. It'll also, in case that's broken, it'll also bind to corticotroph cells and just also knock this out. So double negative feedback system. Don't miss that on the boards. Okay. I think we got all that stuff. All right, we should mention stress here a little bit. So it is well known that chronic stress will drive the release of cortisol. But how does that work? So it stimulates stress, and mechanism we don't completely understand. Stress releases hormones from the brain that stimulate corticotroph cells to overproduce both POMC, or to overproduce, or let's back up. The stress causes the release of CRH and ADH-p about equally. So brain hormones from stress bind to CRH, or bind to parvocellular neurons and cause them to release CRH and ADH-p. So more ADH-p and CRH is hitting the corticotroph cells to drive the stimulation of ACTH. But interestingly enough, it also causes these same unknown hormones and mechanisms. It also causes corticotroph cells to grow way more receptors than they're supposed to for the ADH-p. So normally not all ADH-p is able to drive ACTH production by itself. It just kind of helps, it assists CRH. But in the case of chronic stress, ADH-p is really driving. It's thought, the new research has thought that ADH-p is the one that's really driving the release of ACTH through the growth of more receptors on corticotroph cells. Right. Some other sequelae of chronic stress. It also causes hypertrophy of the adrenal cortex. Just 2 weeks, you can tell. And that's from an overbombardment of ACTH. If you're overproducing ACTH, and cortisol can't shut down the ACTH that well because of those mysterious hormones from the brain, practice makes perfect. And you want to get big biceps, do bench press or do curls. Same type of deal there. The cortex also becomes, practice makes perfect, grows more receptors for ACTH, in the glomerulosa cells become very good at binding ACTH. Or, I'm sorry, the fasciculata cells become very good at binding ACTH, and it over-secretes cortisol that way. And yeah, bottom line is chronic stress, cortisol is way overproduced, and we'll be talking about that soon, all the negative sequelae of that. What about the adrenal androgens? Because we know ACTH binds to the zona reticularis and stimulates reticular cells to release DHEA, or all of them. Here's the adrenal androgens: DHEA, DHEAS, and androstenedione, or androstenedione. I've always learned it androstenedione, but I think the official pronunciation of that most people use is androstenedione. But yeah, so in people with excess overproduction of ACTH, they also have increased levels of the adrenal androgens. So what? What does that do? Let's see. So we'll just do some fun facts first. The adrenal androgens are the major androgens in women. Just kind of a fun fact, right? They don't have testicles, so they can't make testosterone. But yeah, the androstenedione can be converted into estrone, which can be converted right into testosterone. About 50% of their testosterone comes from this pathway. And yeah, they don't have testes, we said. And secreted by zona reticularis. Yep, we know that already. A little bit is secreted in the ovaries as well. Androstenedione can be made in the ovaries of females once puberty starts. And it plays a role in fetal development, which we won't get into. The androstenedione is also made in the male gonads. It's not only made in the adrenal gland. The testes and the ovaries both make the adrenal androgens. In females, of course, it's converted, I said this, to testosterone. Androstenedione is converted to testosterone. In fact, that's about 50% of females. The supply of testosterone comes from that ovarian release of androstenedione. It's banned now, but this was a cheating loophole where athletes, they they wouldn't inject synthetic testosterone, but they would inject the precursors of it, which is androstenedione. If you do an intramuscular injection of androstenedione, it's quickly causes the testes or the ovaries to make really huge amounts of testosterone, and it disappears really quickly. And they didn't have for a long time. They didn't think that to test levels for the adrenal androgens. So that loophole is now closed, though. If you have too much testosterone, it's a huge advantage. All sorts of sports, not only for weightlifting and strength. It causes it causes increased protein synthesis, but one of the key things of testosterone, it greatly increases the recovery time from broken down muscle. So if you do a heavy workout where normally you could only do that heavy workout once a week, if you're on testosterone, you can do that heavy workout twice or even 3 times a week because you recover so fast. But it's everywhere. Archers use it to steady their hands, and it's speed skaters, and it's everywhere. That's all I'll say about that. And so what happens in our case where Cushing's disease, or in our case where we get too much ACTH created, like Cushing's is a good example. So what happens to them if they have too much adrenal androgens? Well, they start to take on male characteristics because the excess androstenedione drives the ovaries to make too much testosterone from that, and they might as well be taking shots of testosterone. And you can see here's a female with Cushing's syndrome, and she's got a pretty good beard going on here, pretty good whiskers. So that's called virilization. They become masculine or male-like. Their breasts dry up. Changes occur to the clitoris as well, where it starts to get longer, like into a penis-type shape. The voice deepens. They get a hypertrichosis, which is hairy. And they get whiskers, and that's virilization. Another fun fact here, remember the adrenal androgens, we don't need 21-hydroxylase to make this. So people with 21-hydroxylase deficiency will have deficient aldosterone and cortisol, but they will still have a normally functioning adrenal androgen count. So remember this thing. I do like this. I'm going to take some of this biochemistry out. You guys are doing fantastic on biochemistry. I just saw the board scores. So I better worry about my own classes now more. So remember, cortisol can go 2 pathways. It can be used to make aldosterone via 21-hydroxylase and aldosterone synthase. It can also be used to make cortisol via 21-hydroxylase. And you don't need a 21-hydroxylase is probably the most common genetic problem with the adrenal cortex. And you don't need it here is the point I'm making. You can make DHEA without it. Notice while we're here, notice DHEA and DHEAS are converted back and forth. And androstenedione here, or androstenedione, is kind of the final step of this pathway. That's why a lot of authors use this as the kind of the main product of the zona reticularis. Androstenedione. Androstenedione can be converted quickly by one enzyme, this dehydrogenase enzyme, and it can be converted right into testosterone. It can also be converted right into esterone, which is one of the estrogens, by aromatase. And estrone can be converted back into estradiol and then estradiol. So estradiol and estradiol, these are the 3 estrogens here. All right. What else does DHEA do, or androstenedione? It causes pubic hair and axillary hair growth. So around puberty, or before puberty, the adrenal cortex, especially the zona reticularis, is really undeveloped and basically turned off. But as puberty starts, the zona reticularis is basically asleep. And when puberty starts, hormones start flowing, the zona reticularis wakes up and matures and starts doing its thing, which is secreting these adrenal androgens. And it can also better respond to ACTH now. At that point in time, when you're starting to turn into a man or woman, that has a name. That's called andronarchy, or when the adrenal gland wakes up, andronarchy. And it ramps up and releases high amounts of these up to the age of about 25, and then after 25 it starts kind of weaning. I guess you start getting old at 25 then, technically. I mean, some sports you're almost done with your career in certain sports by then. Let's see, they also responsible for pubic hair and axillary hair growth. They're responsible for body odor. They also stimulate the sebaceous glands in the skin to kick into high gear and secrete sebum, which can clog the pores which the hair goes in. And if that's clogged, bacteria can get trapped down there, and the bacteria feed on the sebum, and they cause a little beaver dam, which allows them to grow and grow, and you get yourself a pimple because of that, or acne vulgaris. ACTH absence, what about that? What if your pituitary gland is destroyed and you don't have ACTH? You're in big trouble. You have to take tablets or you'll die. You won't get any glucocorticoid release, no adrenal androgen release. Aldosterone will be decreased a little bit, but that's not really the main problem here. Histologically, the zona reticularis and fasciculata will show atrophy within a couple weeks. Again, aldosterone will be normal because remember that's stimulated by angiotensin II, and potassium levels, increased potassium levels. And yep, that's an example of that would be secondary adrenal insufficiency. If you had cancer in the pituitary gland and it took out the anterior pituitary, or all those things that we listed, or tumor. Okay, that is enough. Not too long of a lecture, but some heavy stuff. See you guys later.